extend my warm thanks to our speakers, the researchers, doctors who have come from near and far, some of them from across the street from Emory University, some from California, Michigan, other places. Thank you so much for joining us, and your presence actually shows the commitment of this community to try to advance awareness, knowledge about IgG4-related disease and the care that you have for our patients. So we couldn't make today possible without the support of our generous sponsors. We really thank you for believing in this community and helping us grow the awareness, education, and research in IgG4-related disease. So let's get started. I want to introduce, it's an honor for me to introduce two special people here. The first one is Miss Katherine Provencher, which most of you know her through her work, tireless work in IgG4ward Foundation. Her work in IgG4ward for the past year and a half has really created this beautiful community, and her work has brought us together today here. The second person that I wanted to not only introduce, because he doesn't need any introduction, but also give my deepest gratitude and thank is Dr. John Stone, my dear mentor, colleague, and friend, whose name does not really need any introduction for anyone who is familiar with the term IgG4-related disease. He has been the true leader in studying this condition and has been the pioneer in recognizing this entity to the whole world. Thank you for your mentorship, your leadership, and thank you for everything you are doing for the IgG4RD patients. So, okay, so let's get started. So the task that I was given was to talk to you about the road to diagnosis, lessons from the history of IgG4-related disease. I think Dr. Stone, in a couple of minutes, really elegantly put the road to diagnosis with the example of Marlene, one of the patients who has shared her experience in the IgG4ward. But I want to go through it a little more in details. So you see this winding mountainous road, but I'm sure none of you guys, the road that you took was as beautiful as this looks like here. Majority of you had a slippery, foggy, very cold, dangerous road to the diagnosis. And I have seen it, as Dr. Stone mentioned, for the past 15 years or so, the treating and taking care of patients who go through this journey when they get to my office. So I wanted to just go through a typical journey of a patient with IgG4RD, very similar to what we heard from Marlene. This patient actually, I received an email from a nephrologist who told me that this 67-year-old woman with history of diabetes in the past 2 years was having worsening of her kidney function. So the nephrologist just wanted to know what's going on. The diabetes is not so bad. Why their kidney is getting worse? They did a kidney biopsy for them. And the biopsy showed IgG4-related nephropathy. This was the first time that this nephrologist was seeing this report, had never seen it before. So Googled IgG4-related disease or Googled IgG4-related nephropathy. And one of the names that came up, or probably the closest to them location-wise, was my name and my clinic. So emailed me and said that, is it okay if I send this patient to your estate and your clinic? And asked some information about the disease. I met this patient a couple of weeks later. So she told me that 3 years ago, she had abdominal pain and she had significant changes in her bowel movements. She was sent after waiting for a couple of weeks to see GI doctors. So they did a CT scan of her abdomen, and they told her she had pancreatic cancer because of a big mass in her pancreas. You can imagine what goes through a patient's mind, what goes through a family's of that patient mind when they have this diagnosis. So they did a biopsy. They said, good news, you don't have cancer, and you're good, you can go. but the patient's symptoms didn't get better. So she was having similar symptoms, significant issues with abdominal pain and bowel movements. So they repeated her CT scan and they told her, oh, your pancreas is atrophied, which means that it's scarred. So now you have to take this supplement, Creon or pancreolipase that many of you know, for the rest of your life because it doesn't work anymore. So fast forward, year later, 2 years prior when I saw her, she had lumps in her neck. So she started noticing there were swelling in her neck. A CT scan of her neck showed multiple lymph nodes and submandibular gland enlargement. She said, I'm suspicious you have lymphoma. So she sent her to do a CT scan of her chest. There was a big mass in her lungs too. So she was sent to oncology again. And they checked her immunoglobulin level was very elevated. They did a bone marrow biopsy for her. The bone marrow biopsy came back normal. Again, they told her you don't have cancer. But the timeline of going to the oncology, getting the biopsy, getting the result, again, significant anxiety and stress for the patient and family. So past few months before she came to me, had the kidney issues, kidney biopsy, and the new diagnosis, referral to another state, to a new doctor with a specialty clinic that is a rare disease. So exactly the screen picture that Dr. Stone showed you in the painting, but this is what has happened to many of you here. I saw this lady, and at the time, her kidney function was not good. Her creatinine was 3.48. If some of you guys follow the labs on my chart, know what these numbers are. Her serum IgG4 was 1,328, which is 10 times of the upper limit of normal. So I diagnosed her with the history that she gave me and what I'd seen with IgG4-related disease. I put her on prednisone. And 2 weeks later, her creatinine was much better. Her serum IgG4 was much better. She got rituximab at that time. This was like a couple of years ago. So she has been on rituximab every year or two, and her kidney function is back to normal. She's living a normal life, no more cancer diagnosis or any other issues, although she still has to take the Creon for her pancreas. So what I wanted to bring back over here is multiple biopsies, multiple misdiagnoses, and years of undiagnosis and given different names to the disease was really IgG4-related disease. So if the awareness was there at the beginning and we had better tools to check and confirm the diagnosis, this patient didn't have to go through this. So why is it so hard to diagnose IgG4-related disease? There are so many other autoimmune diseases. We do a test, make the diagnosis for them right away. Although it's not true for majority of our autoimmune diseases, it's not easy to make a diagnosis for lupus or sarcoidosis or other conditions. But one of the main reasons that IgG4-related disease is such a difficult diagnosis is because it affects multiple different organs in different people. So each one of you have different symptoms and presentations to the doctor compared to the other one. Yes, it is possible that in this room we will find people who had similar organ involvement, but it's usually very variable. And you present, if you have a lump in your neck, you go to ENT. If you have issues with your GI system, you go to the GI doctor. If you have a problem with breathing, you go to pulmonologist. So it's multiple specialties that need to know about this disease and make the diagnosis. So it's a disease hiding in plain sight, affecting multiple organs and often disguised as other conditions. So I don't blame the doctors who definitely were worried about that patient, that the mass in the pancreas is cancer, because the diseases that IgG4-related disease mimics can be really dangerous. Cancer, infections, things like that, that should come on top of the list and make sure that's not the case. Otherwise, you miss those kind of diagnoses. So it's a rare condition for sure. Community doctors do not see often, and that becomes a problem. So if you come to a clinic that Dr. Stone, myself, Dr. Baker, who see a lot of patients with IgG4 related disease, the chance of right away getting to the diagnosis is high. But when you see doctors who have never seen patient with IgG4, it's not on top of their list. It's newly recognized, so it takes time for the awareness of multiple specialties. And as I said, symptoms mimic other conditions, and there is no specific test to make this diagnosis. For that reason, the average years to diagnosis has been 5 to 7 years. Hopefully, it's improving rapidly. Is IgG4-related disease a new disease? What happened? Just came out of nowhere or has been there? So if you look at the literature, from 1892, there are evidence in the medical literature that this disease existed. So Dr. Johann Mikulicz in Germany published this paper in 1892, a patient with swollen glands, submandibular glands, parotid, and lacrimal glands above their eyes. And this is a picture of a patient that Dr. Stone and I met in Boston, one of the first patients that we treated with B-cell depletion. So very similar disease and has been there. It's just that we didn't know it. We didn't have a name for it then. Looking at the literature, there are more in 1960s, 1970s that they were describing pancreatitis with swollen glands and everything that is exactly the description of what you have. So in 1970s and 1990s, people were getting recognized for this specific isolated organ involvements. There was no name calling it. They were calling it, okay, a fibrosis or inflammation in your pancreas, liver, lungs, with no name. Doctors weren't able to connect the dots to make it a unified diagnosis at that time. It wasn't until 1990s that in Japan, gastroenterologists noticed that this type of pancreatitis is different from other type of pancreatitis. It has a specific pathology. They started looking why this pancreas in their biopsies has so much inflammation. They started staining it for different things, and finally they noticed, oh, they have a common thing, and that's IgG4. And they started also recognizing the pattern. Dr. Hamano, who is a gastroenterologist in Japan, in 2009 published his research and found that patients with autoimmune pancreatitis, at that time calling it a sclerosing pancreatitis, had elevated serum IgG4 compared to the others. So that was really the landmark or one of the first research papers on this condition that brought the attention of the global community to this disease. It was published in one of the major medical journals. 2 years later, Dr. Kamisawa, who is also a gastroenterologist in Japan, recognized that patients he was following for their autoimmune pancreatitis with elevated serum IgG4 have different part of their bodies getting affected. They have retroperitoneal fibrosis, swollen glands, or inflammation of their aorta. So he proposed a concept that this disease is systemic. It's not just limited to the pancreas. So really, between 2001 and 2003, with these breakthrough moments that were publications coming out, that people were trying to connect the dots and understand this as systemic disease, started to actually grab the attention of the investigators around the world, researchers, to pay attention to this, and medical community started recognizing it more. And that was the time that people started publishing different part of body organs can get affected with this disease. There were more than dozens of names in the publications calling the same condition. And that's when Dr. Stone explained to you that in 2008, when he saw his first patient, started thinking we have to do something. This is a disease that everyone is calling it different names, so we have to bring these people together. So I remember that we were talking about it and we decided, okay, let's have a meeting and get all the people who are interested in this condition in the same room, so maybe we can come up with a consensus for the name of the disease. We searched the PubMed, which is the search engine for medical journals. We found whoever had published any paper on with these names or anything related to IgG4, and I emailed the corresponding author one by one, invited them to come to Boston in October 2011. We all got together. We came up with a consensus of at least a name. We called it IgG4-related disease because that was the most common thing that these people had in the blood and in the tissue. Then that was the start of IgG4-related expert community. After that, we had one after another moments that brought more knowledge and understanding to the disease and awareness for community and providers to be able to manage patients better. So the pathology consensus, which is the statement that the pathologist can use when they're reading the slides to make the diagnosis in 2012. The management guidelines were published so doctors who in the community see these patients know how to treat patients. And then we put together a classification criteria, which is mostly for research, but can help providers also to confirm their diagnosis. And then from that community, we were able to establish international clinical trials with the help and support of the sponsors. So from 2011 to 2025, there was an advancement in understanding of the disease because all these experts and researchers got connected together. So we understood more about the natural history of the disease, how this disease happens, and how to manage it better. So one of the hallmarks was in 2024, ICD-10 code was approved for this condition. I don't know how many of you know what ICD codes are. They are medical labels that doctors, hospitals, insurances use to speak about the same thing. It's a language that they use much in terms of coding. So when you see a doctor, you have a high blood pressure. The high blood pressure has an ICD-10 code that the doctor puts in. So if someone wants to check the system and find out how many patients have elevated blood pressure, they can find it. Or the medications that you take gets linked to that, so insurance approves it. So it didn't exist for IgG4-related disease. So if we wanted to do research to find out what is the incidence, what is the prevalence of IgG4-related disease, we couldn't do it because each one of us that would see you guys in the clinic couldn't give you the same diagnosis in terms of the code before 2024. And that's why we all had problem getting insurances approve your CT scans, infusions, and things like that. So that has gotten much better. Multiple clinical trials and the most important good news, the first FDA approval of the medication that happened in April 2025. So this is... So hopefully now road to diagnosis is still winding, but clear. The fog is lifted. It is safer to drive. And maybe, of course, it's not enjoyable, but easier to drive and get to destination. So what lessons we can learn from the past 2 decades from this disease? Misdiagnosis is going to be common because, as I said, there is still necessary to increase awareness. There are still mimickers that needs to be ruled out. For sure this is going to happen. So we know that. But definitely with the collaborations that we saw over the past decade or so have increased awareness, have increased development and advancement in understanding of the disease needs to continue. So multiple subspecialties need to collaborate to be able to diagnose the patients. They have to share knowledge by publishing in the medical literature, by talking to each other to be able to do it and put together all the information to get to the destination. Lessons for patients. Definitely patients' persistence of how detailed you give us your symptom history. The description that the patient I just told you about, that told me about the 3 years, 2 years, 1 year before, how this happened to her made me better in terms of confirming her diagnosis. Give us the timeline of your illness. Persistent in seeking answers and ask questions. Don't stop with your doctor. Get a second opinion if you can't find your answers. And building the community. This community that we have here with the IgG4ward can really help to learn from each other. So improvements has happened since recognition with earlier diagnosis, fewer surgeries, hopefully no more Whipple surgeries, as we heard from Marlene, targeted treatments that are available, so hopefully no one is going to stay on long-term steroid, and definitely support groups. But still, we need to put everything together in terms of history, physical exam, lab, imaging, and pathology to be able to make a diagnosis. What we are lacking is really one test that you can get done and say, oh, I have IgG4 related disease. That's still needed. We still need global access, broader awareness, and more research to understand underlying causes of IgG4 related disease, more research to understand how to use the targeted treatments that are available and what is the best way to do those. So I want to thank again all of you guys here and IgG4ward. I think we have a couple of minutes for question. If not, then we can move on.
What is the load meter?
Oh, so yes, that's a good question. So IgG4 is an immunoglobulin. Okay, it's the least amount of IgG, which IgG is your main immunoglobulin in your body, and you have 1, 2, 3, 4, and 4 is the least amount you're supposed to have. And this is the shape of how immunoglobulins look like. They have the heavy chains and light chains, and that's why the IgG4ward created that logo also, that the people standing like that looks like the IgG4 molecule. Yes?
You mentioned there is not one test, and I know there's a lot of discussion about therapeutics and advancement in treatment. Are there companies working on a test for this at this point?
Definitely in academia and definitely in the industry, everyone is trying to answer that question, looking at multiple different levels of, in terms of specificity of the different molecules, immunoglobulin. You can find it in tissue, in the blood, even with some of the imagings to figure out what is the best way to put them together, even with genetics, epigenetics, and things like that. So far, I mean, there has been some advancement in some areas that actually have been suggestive of good markers, but they are not yet the one that you can rely on solely. So we use more and more combination of things. So I'm sure you guys have seen most of the time your doctors check not only IgG4, IgE, C3, C4, the complement levels, all them together to help us to understand if your disease is active or is in remission and things like that. But there are multiple researchers and investigators when we have these conferences for IgG4 symposium that researchers present multiple projects are presented. Yes?
Is there work being done to possibly find the difference between IgG4 related like RPF and idiopathic RPF? Is there, without a biopsy? It just kind of, it doesn't complete the puzzle, although there's enough, should be enough there to.
That's a great question. That's definitely a challenge because it's difficult to make the diagnosis without a biopsy. Doctors want to make sure that it's not cancer. So most of the time the biopsy is necessary. But definitely if we can find a better marker rather than just IgG4 staining in the tissue, that should be and could be used for retroperitoneal fibrosis. Yes, Sabrina.
Dr. Kay, the question came up last night, and I believe I've asked this question before, but for the benefit of the larger audience, I'm going to ask it again. So we have the nomenclature of IgG4RD, but are there different nomenclatures that should be used given the specific manifestations? Should we write, I have IgG4RD HP or AIP? What should we use consistently?
That's a very good question. So in that exact paper with the IgG4 related disease nomenclature, we mentioned those because there was a persistent or kind of like emphasis from different specialties that they didn't want to call people who only had autoimmune pancreatitis definitely just IgG4 related disease. So IgG4 related cholangitis, which has the liver involvement, or as you mentioned, pachymeningitis or something else. But honestly, I don't like using those much because, as you heard, this is a systemic disease. If you isolate it again, you are not looking for anything else. Each individual has different presentation, and there may be for many years just limited to one area. But this is a systemic disease. So if you call just IgG4 pachymeningitis, that goes to remission and leave the patient without treatment, many years later they may develop pancreatitis. So we are back to the square one of our first patient, right? It's a systemic disease. I would like to call it a disease that the doctors and providers who take care of that patient make sure they are monitoring everything else. Thank you. Yes.
Hi, this is my first time at a conference, but I wanted to know, the whole premise seems that this is a rare disease, and yet the story you're telling suggests that this disease has been hiding in plain sight and that it's mimicked so many other diseases. And so I just want to understand a little bit better that's two distinctions around the disease, and whether there's any kind of reliable information out there about how many people could actually have this disease and not know it, and what other things those of us who have partners who have it. And a second part of that question is, where besides Massachusetts and here are there hubs of medical professionals that are working on this that we can be more aware of and support?
Those are great questions. So your first question to answer, we don't know the true prevalence of IgG4 related disease because it's been so under-recognized. As I told you, in 2024, the ICD code was approved. Prior to that, I remember in 2012, when I arrived in Atlanta, I met actually with one of the CDC scientist who was working in epidemiology of rare diseases to do epidemiology study. And at that time, I was told that it's too premature because there is no ICD code, the diagnosis, people are not aware of that, so it's not going to happen. In 2019, Dr. Zach Wallace, who is a researcher in this condition, did a commercial insurance research understanding how many people have diagnosis of IgG4RD. And it was like the rate of 5 per 100,000 people have that, 5.3, I think. But again, it's an underestimate because there was no ICD code at that time. And as the awareness is raising and the community is waking up to this condition, I'm pretty sure the number of people who are going to be diagnosed with this disease and have been living with this and following with their specialties separately will come out, and we have better understanding of the true prevalence of that. For your second question, there are definitely multiple centers in the United States and in the world working, treating patients with IgG4RD and doing research on that. We have speakers here who are coming from, we have Dr. Matt Baker from Stanford, we have Dr. May Sami from Michigan, Henry Ford, but in IgG4ward website, there are networks of physicians that actually have volunteered and are interested in treating patients with IgG4 related disease or already have centers. There is hope that we're going to have IgG4RD centers of excellence pretty soon that would be providers who are well educated about this disease. They are connected to the community and can do a better care of patients and also contribute to the research that is going on in the community. We have time for one more question, and you can use the microphone over there.
Hi, my name is Pari Jyotishi, and I'm very, very grateful for this opportunity. My question today is, the ICD code that you have, is that used to do blood work for patients like us? Because I go to a rheumatologist, he does a set of blood work, but then pulmonologist does another set of blood work, and my hematologist does, and I cannot understand anything of any of the blood work. So there is no common blood work that any one physician does, or a group of physicians do, and they don't talk to each other. So we are in a jam.
Yeah.
Every week you're going to some other physician and they're doing their own thing.
Yeah, I'm sorry. And I know, I mean, it's not just IgG4RD. I'm sorry to say that, but it happens a lot in our medical system. But you are definitely right. When you, as a chronic autoimmune disease, when you could go to different doctors, each one of them look at you and with their own lens and what the aspect that they are looking at. But ICD code had nothing to do with that. ICD code is just a label to give the diagnosis so the insurance would pay for the blood work that you do. But definitely, this is a need and a necessity that we need in this community to come up with a guideline how to manage patients with IgG4-related disease. First of all, how to treat them, what kind of blood work, what kind of imaging, testing, scans, MRIs they need, how often they need. That's something that the experts need to get together, use the evidence that is out there published based on the clinical trials and other research that is going on in the community and put it together, which Dr. Stone has suggested to lead that through IgG4ward Foundation pretty soon. Okay, thank you.